Does it sound like science fiction yet? Sort of science fiction. Hopefully this will be fun. And it is a topic that we've been excited to explore. So I'm gonna lead you through how we wound up making this question and beginning this work. And hopefully you will have some questions. So we'll quickly go through a lot of data. I've talked to you twice before about different things we do for resuscitation and cardiac arrest. And so you remember that clinically in your own practice, you're doing hypothermia for treatment of brain injury and different kinds of medical problems. Reminding you that hypothermia does certain things, that we can use it as a tool to treat seizures or swelling or perhaps even to manipulate metabolism. I described how we have adopted hypothermia in our clinical practice for particular kinds of patients and how to use that. This is something we have done for 2 decades, for 20 years. For 20 years, we have done hypothermia as a medical treatment. And for 50 years, doctors have tried it, though it was not successful and it was not always in the type of application that we do today. So this is old. This is old information. And our group, like you, work with critically ill patients, and we study many things about hypothermia. So this is research we have done for many years. But we were interested, if it was good for critically ill people, might it also be useful for different kinds of situations? So situations like acute myocardial infarction or stroke, trauma. You know, if somebody has exsanguination, would they tolerate the low flow better until you had a solution to their problem? So what's different about all of these patients compared to the ones where we've used this? Well, they are awake. And, you know, making hypothermia on an awake person is very different than taking a comatose patient who is anesthetized and making hypothermia. So that was a challenge we had. And we became interested more than 10 years ago in whether we could adapt what we had learned in comatose patients to awake patients. And we had a number of questions to answer. This was the first one. When we meet somebody having acute myocardial infarction or acute stroke, we hurry to reperfusion. So you meet the patient and you are very quickly moving them in the ambulance, trying to get them to angiography to either open this artery or open that artery. And, you know, it ideally is only minutes, maybe it's hours, but quickly. So if we're going to use hypothermia to improve the tolerance of the brain or the heart to ischemia, we must begin it very quickly, within minutes. So can we do that? And what are the requirements? Well, it needs to be rapid. It needs to be done to awake people. And that means that they need to spontaneously breathe. So, you know, those are the basic design requirements. And rather than jump to people having medical problem, we got volunteers. So here's one of our volunteers, is one of my partners, is Dr. Rittenberger, who did lots of this. And he had a great philosophy that for any experiment, if the experiment was a good, safe experiment, he would always be the first volunteer. So when he designed a laboratory study, he always tried to be subject number 1 for any protocol, so that every other person who volunteered, he could tell them that I did this, and I believe that it's safe. And we began with this type of experiment. Can we use rapid infusion of cold IV fluids to lower body temperature? And this will be familiar to you. This is old data. This is things that we've done over many years. We're going to lead up to space travel. But this is the design of our experiment. We place an IV catheter. We have people take a thermometer pill so that we're measuring their temperature in their stomach. So they swallow a capsule that has a thermometer. And we can infuse saline either at room temperature or at 4 degrees, so cold IV infusion through an IV quickly, and we see if the temperature goes down. Simple experiment. And we get results like this. You can see each curve is an individual person, and over minutes, the body temperature starts at 37 and goes down to 36, 36.5. If I use cold saline at the bottom, it can go down 1 degree or 1.5 degrees. 30 cc's per kilogram is about 2 liters. So not huge volume, but you get almost 2-degree change in body temperature. It doesn't seem physically possible, yeah? How can this small amount, 2 kilograms of fluid, make a 70-kilogram person drop 2 degrees? Does it add up? You know, the trick is really that your body temperature is not the same through your whole body. My arms and legs are colder. They're closer to room temperature than my core. My torso and my brain are maybe 37 degrees, but my arms are maybe 28 degrees, 30 degrees. And if I give cold fluids quickly and I get it into the middle, I only need to reduce the temperature of my core. My core is maybe only 30 kilograms. 2 kilograms of cold fluid to 30 kilograms, yeah, temperature drops 2 degrees. So it's possible to lower temperature quickly with this kind of intervention. But it is not comfortable. So skin temperature didn't change, heart rate decreased, but we had a scale for comfort. And everybody said, this is terrible. This is horrible. I think this is very uncomfortable. So if we began to do this to patients, patients would not like this at all. They would be very stressed out. And people shivered, like Rigers. So if you do this to an awake person, they get, shaking, shivering, very, very brisk. We gave meperidine, which I don't know if here the name meperidine is the drug, to suppress the shivering. And it worked okay. It was 25 milligrams. We did it as needed. And this experiment really taught us, though, that shivering was a very important feature of cooling somebody who's awake that you must control. So meperidine worked, but we wondered, could we do something that's more long-lasting and maybe doesn't have the respiratory depression over time? We were thinking about neurological patients, and meperidine has metabolites that can increase seizures. So, we had reasons to look for other medicines. And also, when people shivered, we would give the cold IV fluids, but if they're shivering, they warm back up very quickly within 5 minutes, 10 minutes. And you can't just keep giving fluids, yeah? You would like to cool them down and keep them cool. You can't repeat the fluids over and over, 4 liters, 6 liters. It's not practical. So we tried this experiment with diazepam. We picked diazepam simply because this was a drug that our paramedics carry on the ambulance. So we went to that one for convenience. It was one that was widely available on the ambulance. But again, we're in the laboratory, we're taking healthy volunteers, and we give them diazepam, 10 milligrams or 20 milligrams, same intervention, cold IV fluids, and we see, can this suppress shivering? And we got a little more sophisticated. We also measured metabolism, because shivering, if I want to measure it, I look at you and I look to see if you're shaking. And I write on a scale, this person is shaking 1, 2, 3. I give a scale of shivering. But you might actually have some muscle tone and I can't see it. So it's more reliable if I have some kind of machine measure, am I making heat? So we used a metabolic cart. We had people breathe into a mask and measured the carbon dioxide and oxygen consumption. And we could see their VO2. And as the person had their temperature drop, if they were shivering, their VO2 would go up. And you can see if we gave placebo, the body began to make more heat by shivering. It consumed more oxygen, and maybe the oxygen increased 50% from baseline, from resting. But if I gave diazepam, it's that bottom curve, 20 milligrams of diazepam blocks this. It's a pretty good dose. People are sleepy. So, this is a single, rapid dose of 20 milligrams diazepam is fairly sedating. Respiratory rate, okay. End-tidal CO2, okay. So it's safe, but sedating. So we answered that question. You know, we can actually suppress shivering with a drug, and it didn't really make people more comfortable, though. While they did not shiver, they still said, this feels terrible. It's very uncomfortable. I don't like this feeling of being cold. So I feel cold, even though I don't shiver. We actually separated two things about people. Shivering is one behavior. Feeling cold is a different behavior. Two different things. Shivering better. We kind of see that we're thinking through, am I able to apply this to patients? And I'm trying in the laboratory with volunteers to try different things to come up with a recipe to treat maybe someone having a myocardial infarction. Let's try other drugs. In this case, we used midazolam, and we gave up to 6 milligrams of midazolam. We were interested in metabolism, and that was a study we did with our pharmacy colleagues. And we also followed it with a lorazepam infusion over 3 hours, because we were very interested in that time window of when the patient having a stroke comes to the hospital, gets scans, goes to angiography, begins to recover after reperfusion from their stroke. We would like to control their temperature for 2 hours, 3 hours. So this was beginning to imitate that. And we thought diazepam worked, maybe midazolam will be okay and produce this effect. And there's a literature about using magnesium to suppress shivering. You've heard this, or you guys, anybody use magnesium for shivering? Yeah. So we thought, you know, that magnesium never does anything bad. So we should add it and test it. That's safe. So we tried magnesium, and we got these results. You see there now we're looking at much longer time, up to 5 hours. With warm saline, temperature drops a little. When I give cold saline, temperature drops as much as 1.5 degrees quickly. With magnesium, it's a little more pronounced. And then the patients now with these infusions, they begin to rewarm, but not so quickly as with no infusion, or as our first experiment. So we're beginning to keep the temperature down and suppress shivering in patients with these drugs. Graphed a different way, looks like that. And you can see the total amount of cooling over time, sort of that area of the curve from baseline to where they were, that giving cold saline plus magnesium, 6 milligrams of midazolam, lorazepam infusion at 1 per hour, to cocktail, but it keeps body temperature down. And I'm beginning to do it now for hours. That's almost maybe enough that I could think, would that help for a stroke patient or acute MI patient? We were interested in metabolism. That was the reason for that study. And we studied midazolam elimination. And our pharmacists did blood levels, plasma levels of midazolam, and compared it in the same person with the different interventions. Every volunteer did all 4 drug conditions. And so we were able to get estimates of the model of clearance. And we made this finding, which you will see in textbooks now, is actually how much does hepatic metabolism change with you manipulate temperature? About 11% per degree reduction. And midazolam is a CYP3A4 metabolized drug. So that pathway, which is responsible for many drugs, is temperature sensitive. So if you're giving a drug to a patient who has their temperature manipulated and lowered, clearance will be slower. How much slower? About 11% per degree slower. So now your half-life will be prolonged some amount as you take care of that patient. So that's useful information. We also were interested in dexmedetomidine. Why? Remember, we began with meperidine, and we tried other drugs and we did not have great success. And at the same time, I was taking care of cardiac arrest patients, and sometimes they would shiver in the ICU, and we would try different drugs. And we noticed meperidine was very good, midazolam or diazepam at high doses was pretty good. Fentanyl, not so much. It did not suppress shivering very much. Other opioids, not so much. So what was different about meperidine? Meperidine is a messy drug, and I hesitate to discuss these drugs in front of anesthesiologists, but it also has alpha-1 adrenergic receptor binding properties, like dexmedetomidine. And we looked at the basic science literature. Those receptors are involved with temperature control. There are receptors in your hypothalamus with alpha-1 adrenergic binding properties. And we thought, well, maybe other alpha-1 adrenergic drugs would be effective. So we tried dexmedetomidine, a bolus, single bolus, no infusion, just 1 mic per kilo of dexmedetomidine per placebo. We cooled the person, same way, IV fluids, and then we watched over 120 minutes. Important safety point. When you give bolus dexmedetomidine and you start infusion of cold IV fluids as fast as possible, it's boom, boom on the heart. And we had one patient who had a very long pause. When they had a very long pause, I had a very long pause. Subsequently, we never did that simultaneously. Yeah. So if you do those together, it's too much. And we got away with it a few times, but I think it's important to remember that these drugs have AV blocking property, and that these cold stimuli are very vagal, and the discomfort that people feel adds to that AV block and can create a problem. Nevertheless, it works really, really well. So you can see 2 hours with placebo, people cool very quickly and then they warm back up. But with 1 bolus, no infusion, just a bolus of dexmedetomidine, the person cools, stays cool. They're shivering, they did not have any shivering. Their comfort, yeah, it still feels cold. If you ask them and you can wake them up and say, do you feel cold? They go, yeah, I'm cold. It's like 3 out of 10. I feel cold. But they're not too sedated. That's Richmond agitation scale, so -1. So easily arousable. Some people never close their eyes. So it's mild sedative level, but very, very good for shivering. And so good that you can lower body temperature and keep it low for a period of time. I like that. Blood pressure is okay, comes down a little. Heart rate comes down more significantly. Heart rates in the 40s are common, and breathing is okay. So it kind of is checking the boxes for what we were looking for. We also drew plasma levels, and generally we were in this range. I don't know if this is a drug where you check plasma levels, but the literature says that you start to get sedation around 0.1. 0.2 is more comfortable sedation, all the way up to maybe 1.5 or 1.9 when you have deep sedation, where people can become unarousable. And the hemodynamic profile of dexmedetomidine varies across that as well. We're working in this range, under 1, above 0.3. That's where the sweet spot for these effects are. So now we're ambitious, and we were thinking, can we do this for longer time? 2 hours was pretty good, but what can we do? My partner, Dr. Rittenberger, again, was subject number 1, but we began with a bolus of dexmedetomidine and then continued an infusion. And we looked to see, could we lower the temperature quickly and then use surface cooling to keep the person cool for a longer period of time. We're going to try for 3 hours now. And it had experiments that start to look like this. So in this one, unfortunately, we were not swallowing the capsule, so people had a nasal esophageal temperature probe. Very unpopular. people asked that we go back to the capsules after this experiment. So we only did this one experiment with the capsule. The cooling pads, I don't know if you used them, but they are Arctic Sun. This is a company that makes a gel adhesive pad. It has water that circulates next to the skin and it adheres to the skin. You can use them for up to 7 days. They're nice device to control temperature. It plugs into a console just like the controller for a endovascular catheter, so you can have feedback and control the patient's temperature. Works really well. So we used those in these participants, and we found that we could cool people for about 2 degrees, 2.5 degrees, down to 34 degrees, keep them cool until we turned it off at 3 hours, and then they warm back up over an hour or so. So we're keeping people cool. They have some shivering, minor sedation. We say it's very uncomfortable. So it's not pleasant, it's still uncomfortable, you're still feeling cold. We also had that bradycardia. We were a little bit concerned about the bradycardia because I've been doing these experiments in healthy people, but I'm wanting to apply it to patients who have heart disease. Maybe they're having acute myocardial infarction, or they have a stroke, so they maybe have other problems. I can't screen them, so would this be safe? We thought, if we could eliminate this bradycardia, that might actually make this kind of regimen more safe. We explored some things. Glycopyrrolate was one possibility. We thought if we remove vagal tone, then maybe we would help the heart not be so slow during this cooling. So we did the exact same thing, bolus dex and then infusion. Based on the last series, we learned not to start the dex at 0.5. We started at 1 because 0.5 is all those people we saw had shivering in the last experiment. And we gave them different doses of glycopyrrolate. It doesn't work. So the heart rate goes down. It goes down the same, glycopyrrolate or no glycopyrrolate. It's partly related to temperature. So the temperature goes down, and then the heart rate goes down in proportion to the temperature. They're very correlated. There's probably some direct effect of dexmedetomidine, but a lot of this bradycardia is the physiological slowing of the heart as the temperature goes down. Anyway, glycopyrrolate or atropine, I would not count on it to reverse the bradycardia if you have a problem with dexmedetomidine. So let's sum up where we are so far and see if we can go to space. We can suppress shivering. So we found a couple of drugs, and my favorite drug is dexmedetomidine. It's very effective, easy to give, easy to dose, works reliably. Just has this bradycardia is my biggest complication. We can lower body temperature for 2 degrees for up to 6 hours. So now we've done experiments. I've shown you graphs where everybody's temperature is low for 2 hours. And they're arousable, they're breathing, they're not anesthetized, they're sedated, but they're not anesthetized. And we kind of think this would reduce metabolic rate. So let's take a little aside and talk about temperature and metabolic rate. I began by saying, hypothermia does certain things. It lowers seizures, it lowers metabolic rate, it lowers swelling, but I didn't show you any data that says metabolic rate goes down with temperature. It just seems like an obvious thing. So are there data? You have to go way back. This is a paper from 50 years ago, 1968, and they looked at dogs. And they measured, just like I was with the metabolic cart, how much oxygen the dog uses, and then they did things to cool the dog down. They also measured brain oxygen consumption. You can do that by, say, looking at an arterial gas and then looking at a jugular gas and looking at the difference to see how much oxygen the brain is extracting, yeah. And it like curves like this. So you see the temperature goes from 37 degrees down to 27 degrees, 10-degree drop, and the metabolic rate drops in half. They describe it in terms of a Q10. If you were hoping never to hear physiology again and never to be in a class where there's, discussion of things like Q10, here it is. It's a ratio that I think is fun to remember some physiology, because we're about to learn a great deal from physiologists who study animals, not people, and see if we can apply it to people. The Q10 is the ratio of rates of anything over a 10-degree change in temperature. So if I'm looking at like the metabolic rate of the brain, it will go up as temperature goes up. And if I go up 10 degrees, the Q10 says that that metabolic rate goes up 2.3 times in this graph. So it's nothing more complicated than that. And you can fit a line and find the slope of the line. You assume it's a logarithm, and all the things you do in chemistry. And in fact, those are real data from the anesthesia group, who was looking at circulatory arrest for doing cerebral protection during complex cardiac and aortic surgeries. So they report the Q10 for the brain is 2.3. Most biological systems have a Q10 somewhere between 2 and 3. So this is what you expect from just the physics of how enzymes change as temperature goes down. So we thought, we have a laboratory and we have a metabolic cart and we're manipulating temperature. We can do that too. So we can take our volunteers and actually see what is the metabolic rate change as we cool people down. So we got the metabolic cart and we put a canopy over the person. You can see the towel there. So it's a little bubble over the head so that we capture all of the exhaled air. And then it runs through the metabolic cart, and you see that it's measuring carbon dioxide and oxygen, and it's telling me the rates of carbon dioxide excretion. I can calculate energy expenditure from that. That's just an equation that you use from VO2 and CO2. And I already showed you earlier how you get somebody's temperature down. So I have cooling pads or IVs. I can make people's temperature go down, and I can make them not shiver by giving them dexmedetomidine. So we did that. And then we graphed out what were people's metabolic rates at all the different temperatures. So if I took John and he was 37 degrees and I cooled him to 36, I measured his metabolic rate. Then I cooled him to 35 and I measured his metabolic rate, all in the same day. And again, shivering is really, really important, because one person, the curve looks like this. VO2 goes down as you get to 36 degrees, goes down more at 35 degrees, but at 34 degrees, they start to shiver, and you see that the VO2 goes way up. If I want to suppress metabolism, you cannot shiver. Shivering is the opposite of what I want. So lowering temperature to reduce metabolism does not work if I allow shivering. Think a moment about the patient you have in the intensive care unit who you're treating for brain injury. When you cool them, are you certain that you're cooling them and lowering metabolism? Or is their anesthesia inadequate and they shiver, and I'm actually cooling them and making them stressed and they're having higher metabolism? Are those two patients, those two situations, actually, one might be therapeutic, one might be detrimental? Are you thinking of that when you treat that patient in the intensive care? I wasn't carefully thinking about that until I saw this. I was thinking if they shiver that it was just interfering with me lowering the temperature. But now I'm wondering, when they shiver, am I actually creating stress that the patient did not need? So remember that curve. If we exclude the people who shivered, I got a nice curve where my Q10 was 2.8. And another way of expressing that is that the metabolic rate decreases 5% per degree. So actually, yeah, and my colleagues who are volunteering for these experiments us in the laboratory, we lower our metabolic rate a detectable amount with hypothermia. So we've done these studies, and you can see my motivation was things I could do maybe in the ambulance to treat medical situations and get people through reperfusion or damage control to provide this as a medical therapy. We would always joke about that this is how people will go to space. You know, that was the science fiction part. And as we're doing these experiments, you know, it was like a laboratory joke. You know, maybe this is the beginning of hibernation for space travel. Lo and behold, a few years ago, NASA had a request for proposals to say, you know, has anybody studied hibernation so we could go on long duration space missions? Those are a long ways away, but it sounds like a very difficult scientific problem. So maybe we should start working on it now, 10 or 15 years in advance of having to use it for that kind of space travel. So we thought, that's what we do. We should apply to that. And, you know, we did. And we had to learn a lot about space science. So next 10 minutes, I'm going to talk to you a little bit about what astronauts have to worry about. The first thing is space is really, really, really big. Things are very far away. These are the two lead proposals for how people will go from Earth to Mars. I don't know when they'll do this, 10 years from now, 15 years from now, sometime like that. One way, it requires 10 months with current technology in the rocket, just leaving Earth to get to Mars. And you stay on Mars for a while, and then it takes 10 months to come back. The other way, if the planets are closer, still takes 6 months in the spaceship. This is longer than pretty much any mission that people have done. There have been a few episodes where people have stayed in the space station close to Earth for 1 year, but that's a small number of people. These total missions all add up to 2 years or 3 years. So these would be the longest times any human has been in space ever if they actually do this. And things happen. One thing is radiation. Radiation causes cancer, causes cataracts. You measure it in grays if you're a physicist, or sieverts if you're a biologist. Neutrons get like this quality factor. Neutrons damage your DNA more, so you have the same amount of radiation from neutrons gives you more sieverts than the same amount of radiation from X-rays. So there's badness in radiation, and the doses are significant. I put up there some medical procedures like chest X-ray and CT scans, and you can see that if you work in nuclear medicine here, usually you're allowed to have 50 millisieverts per year. So if you have a badge that you wear, you know, if you go over 50, you clock out and you can't go back to work until, next year. But if you live on the space station, you get 160 per year. And the estimates for a trip to Mars are higher because, the space station is behind the Earth half the time, right? So the sun is not hitting it 24 hours. So when they go to Mars, there's no Earth to protect you half the time, and the dosing is higher. So the estimates on a trip to Mars are going to be 500 millisieverts per year. Currently, NASA lets astronauts get up to 1,000 millisieverts in their whole career. So if you began to be an astronaut at 30 years old, until you retire, you're allowed to get 1,000, and they don't let you fly after that. So, the doses is significant. You also don't have gravity. And you remember that you make bone and muscle in response to stress. So your bones remodel based on where you're putting weight and so forth. And astronauts lose bone growth because they aren't loading their bones when they're in weightlessness. They're also not working their muscles the same, particularly legs and back. One of the models that NASA uses is actually forced bed rest. So they have experiments where they'll have volunteers lie in a bed, a hospital bed, for 6 weeks to see bone loss and muscle loss in order to test things that will help astronauts not have this. Here's some data from astronauts. It's what percentage of bone density is lost and how many people had that. And you can see a third of people had more than 10% bone density loss in some groups, mostly in the spine and the legs. Body weight also. Typical missions, you can see the duration of missions in days. Space station here on the side closest to me. Pretty typically, people lose 5% of their body weight, and it's mostly muscle. So that is, again, in the legs and the back. And you'll see astronauts when they return to Earth, everybody's helping them around a little bit. It's partly their balance, but it's also kind of they're afraid that, they aren't going to know what's going to break. So the countermeasures currently are crazy. How do you exercise and load the muscles and bones when you have no gravity? This is a contraption they have on the space station. They put bungee cords and springs to hold you to the treadmill, and then they run on the treadmill as if it's a treadmill, but with springs to hold them down. This is required 1 hour a day in order to keep the bone loss and muscle loss from being debilitating when people return. I also pointed out space is big, but spaceships are really tiny. This room is bigger than the living space that will be available for people going to Mars. Maybe they will live in a space half or 1/3 of this room for 3 years. And there's no taking a walk outside. And there's no changing your roommates. So the psychological stress of that confinement makes space, it's a paradox. Space is claustrophobic. You're trapped in a bubble. You cannot leave that bubble. And it's going to be a really long time, longer than we've ever sent people. There have been experiments on Earth to try to simulate, what that stress is like. And they'll lock people up in a chamber for a long time. This was a study done. This one was done in Moscow, I believe. And these 6 men, all men, lived in a chamber for 520 days. I always laugh at the picture, because the one guy on this side won't stand close to, they told them all to get together for a picture, but he won't stand next to the other guy. So you can see that there was, tension. And they have very detailed data on, on day 300, the people inside the chamber stopped obeying orders from the outside. And they didn't obey orders again for 2 weeks until, they worked out their anger. So there are major behavioral issues that would compromise a mission from the confinement. And people get depressed. So, it's the isolation and the claustrophobia can lead to things that would very much jeopardize the mission.
The same vascular surgery.
It's like the hospital. Yeah, COVID was the ultimate simulation. Yeah. It also it requires you to pack groceries. So when you have metabolic demand, you have to carry everything with you. There is no resupply. So that is expensive because everything you launch, it requires fuel to get it there. And one 70-kilogram astronaut may consume 300 or 400 kilograms of food, just food. Now, the air they breathe also has weight. And it's easy to recycle oxygen. So apparently it's easy for the engineers to make oxygen, but getting rid of carbon dioxide is expensive. And that's actually a thing where it's expensive enough that NASA tolerates a higher CO2 in spaceships than we have on ground. In this room, the CO2 maybe is 0.5, 0.6 millimeters, something not high, but on the space station, it goes up to 3. They picked 3 because they used to let it go up to 6, and everybody had a headache. So they backed it down to 3, where nobody complains much, but they can still detect, and these are kinds of experiments people do, you can still detect that people's performance is a little bit impaired even at 3, even though they don't have headaches. So, why would we explore hibernation as a countermeasure? Why is NASA interested in that? Well, it's got data from animals. And this is where the biology is important, because biologists have been studying this in animals for many, many decades. And different animals have this strategy to hibernate. Hibernation, to define it, is a period when an animal sleeps much longer. Maybe it even lets its body temperature drop. It does it during times when there's not access to food, or there's not a good environment for it to be awake and doing its normal things. Bears in the winter, ground squirrels in the Arctic have different strategies, and they're a little bit different. Some of the things that are really interesting to NASA, though, are hibernating animals are resistant to radiation. I didn't expect that. That's a weird one. Experiments all the way, again, back to the 60s, 1969, took squirrels that were hibernating, gave them lethal doses of radiation, and the animals that were hibernating, when they got irradiated, didn't die as much as the animals that were not hibernating. And if they warmed the animal up shortly after they got irradiated, then they died kind of in between. So hibernation protects you from radiation. I didn't know anything about that before we began this project. And NASA's very interested in that, because remember that big dose for astronauts? They're going to get half or maybe their entire career worth of radiation on a trip to Mars. What if we only made that half as bad? That would be a great saving. How it works is still not known. Lots of basic science to be done. People think it has something to do with the DNA breaks. Radiation goes through, it breaks DNA strands. If you break one, that's okay. Your body can repair it using the other one as a template. But if you double break the two strands of DNA, then they have to either find themselves back, or they get put back together wrong and you get cancer. So when you're hibernating, apparently the folding of DNA is different, and the temperature is what matters. And it can actually make those double breaks either re-anneal or not get repaired wrong as likely as others. That's kind of a cool thing. I had no knowledge of that before this project. Bears, when you wake them up in the spring, you should not assume that they're weak and their muscles are wasted and their bones are going to break. The bear will win if you challenge the hungry bear. So 6 months of sleep, that bear is ready to go. How come they don't get muscle wasting and bone loss? May have to do with gene expression. Maybe it's something about bears. Maybe it's the lower metabolic rate. And then, the ones that we actually felt qualified to weigh in on was we can reduce metabolism. I had just done an experiment where I showed that in my healthy volunteers, I can lower metabolism, and I can keep people kind of not awake as much. So if I'm 6 months in this room with 6 other people and I'm awake, 16 hours a day, maybe there's opportunity for stress and friction. But if I sleep most of the time and I'm only awake 4 hours a day, the trip is going to seem a lot shorter, and maybe we don't have a fight. Yeah. So reduce resource use, reduce time for psychological stress, maybe something with bone and muscle loss, and maybe some radiation benefits. Here's the principle. Let me work through the math. Here's the solution we proposed and that we're working on. If I am awake 16 hours and I sleep 7 hours, and then I have to exercise to prevent bone loss because I'm an astronaut, I'm going to use some calories and some energy. I like to use the metabolic equivalent, the metabolic rate, or the resting metabolic rate, which is easily converted to oxygen use or to calories, if you prefer those units. But I like it because it's around 1. So if we're just all sitting here, our metabolic rate is like close to 1. If I'm sleeping, it goes down a little. If I exercise, it goes up to maybe 7. So that's my budget for the day. That's how much energy I'm going to use in a day. Maybe 35 net hours. And if I do the math, I convert that, it's going to be about 2,400 kilocalories. It's going to be about 500 liters of oxygen. So that's the cost of me living on a space station if I have a normal sleep pattern. But what if I reduce some things? Well, if I sleep more hours per day, then I'm going to spend more time at that lower rate. And I could go from 35 down to 29. I could reduce my expenditure 18% just by sleeping more. That's pretty good. And if I could actually lower my metabolic rate when I'm asleep, not ridiculous amount, not like the ground squirrel where I go 95% suppression of metabolism, but more like the bear where I reduce it by 20 or 30%. I can get another 6%. And the combination of those two things multiply together. So if I sleep 7 hours at 0.9 mets, and I switch that to sleeping 20 hours a day at 0.6 mets, still exercising for half an hour a day, I can reduce my energy consumption by 40%, which is substantial. Instead of 500 liters of oxygen, I'm using 300. I'm only having to pack 300 kilograms of food instead of 500 kilograms of food. And, you can kind of do a plot. You can see that I could get 30% reduction if I could get some reduction in basal metabolic rate and increase the sleep time per day. So this is what we propose is our solution for NASA. Let's not try to sleep all 6 months where you don't wake up. Let's see if we can sleep 20 hours a day and have a lower metabolism the way we've done in the laboratory. Arousable people, spontaneously breathing, but there's some additional requirements compared to my in the ambulance application. Astronauts are not going to start an IV every day. We're not going to keep an IV patent for 6 months. They're going to have to self-administer this. So it needs to be safe and something you can do over and over. We think it should look like this, that you, instead of having your usual pattern where you're awake 70% of the time, we're going to be awake 20% of the time. But a few hours a day, everybody will get up, be able to toilet, eat, clean, and then go back to sleep. Okay. What about temperature? Don't those animals lower their metabolic rate with temperature? I began talking to you about this because hypothermia, that was my entry into hibernation was hypothermia. And again, physiologists have been looking at this for almost a century, actually. And there are a lot of models of how animals spend energy and its relationship to temperature. So a little more physiology. This is the classic model. It considers the animal like a chamber that has an engine inside. And if I want to keep that chamber at 40 degrees, I need to put some energy into the motor and it'll heat up the chamber. So that's the way an animal keeps its body temperature up. Some animals have a little bit of insulation. Some animals have a lot of insulation. The more insulation you have, the lower the temperature can go before I have to turn the motor on and start giving more energy. But if I plot energy use on the y-axis and temperature on the x-axis, as the temperature goes down outside, some animals are fine, but eventually they have to start running the motor and their energy requirement goes up in order to keep their body temperature okay. Let's get real data. Polar bear is pretty good until the outside temperature gets to 0, and then their metabolic rate starts to go up. Some ground squirrels are good down to 10 degrees, and then their metabolic rate starts to go up. So actually, it's the opposite. These are animals are like, when I cool them off, their metabolic rate goes up. And in fact, if this room gets colder, your metabolic rate will go up because we're defending our set body temperature. Depending on who you are, raccoons are a tropical species, so they start revving their metabolism when the temperature gets below 30 degrees. Lemmings, the Eskimo dogs are the best insulated. So they don't even blink until the temperature is like minus 20, minus 30. So, if you want to go to the Arctic, take your Eskimo dog. They don't even feel it. It's opposite, because the lower temperature makes increased metabolic demand, and it goes up like this. So basal metabolic rate is the temperature, is the metabolic rate, energy consumption I have just to just sort of be in a happy environment that I'm adapted to. Humans are tropical. Our ancestors grew up in an equatorial region. So we're happiest kind of at 20 to 25 degrees. That's why your climate control in your house may pick temperatures around there. Those are the thermoneutral zone for humans. And people study this because maybe people have different regulation and that results in obesity or skinny. And real human data looks like that. As the temperature changes, metabolic rate goes up when people start to get cold. Just like that person I showed you who shivered and their metabolic rate went up. Hibernating animals do exactly the opposite. When the animal's hibernating, temperature goes down, metabolic rate goes down. So their curves look like that. You see it goes below the basal metabolic rate. It has that downward curve. This Q10 is there to show you, since now you know what Q10s are. You can see the body temperature of the squirrel or the bat can go all the way down close to freezing. So this was our challenge. Are we cooling people off and lowering their metabolic rate? Are we imitating hibernation with those red curves? Or are we going to have something like the top curve, which is what animals normally do? Can we imitate hibernating animals? Okay, you know the design requirements. Here's what we've been doing. First, we have to pick a drug. When we pick a drug, I proposed alpha-1 adrenergic agonists because they all have been given to humans before. There are other drugs that might be related to the physiology of hibernation, but so far most of them have never been given to humans. There's a host of drugs that are approved for something, or maybe you even use them for sedatives, and they have different properties that might be suitable. So we went to the laboratory. We put monitors all over the people. We put cooling pads. We gave them a drug, and we measured blood levels. We looked to see if we could get them to drop their body temperature and imitate the hibernating animal, and then look to see if they recovered okay. And because these are going to be astronauts, we did some psychological testing, reaction time, and so forth to see if it had hangover effects. So similar experiments to what we did before, but no IV drugs. That's our requirement, no IVs. Data flow looks like that. That's more for design. And there's the metabolic cart and our monitoring montage. I just put up here so you can see how temperature, what we're calling core temperature. You can get these capsules that are that big. You swallow it, and it has a radio transmitter that tells you the temperature wherever the capsule is. So my measure of core temperature is a gastric or gastrointestinal temperature that stays in the body for 24, 48 hours. You can see that it's in the room, and the person swallows it, and then it starts to give me body temperature until it passes through. So these were actually a product of the space research. They used these in astronauts for a while. And it's a good surrogate for core temperature. Sublingual dexmedetomidine was our first one. So I took Dex, instead of giving it IV, just put it under the tongue. And the metabolic rate went down up to the bottom at about 120 minutes after you do that. And then core temperature went down. And this was the first experiment, and it surprised me. I started to say, animals lower their metabolic rate by lowering their temperature. But look, their metabolic rate here goes down first, coming back to normal, and then the temperature goes down. It was different than what I was thinking. And I realized that it makes sense. It has to make sense because it's what really happens. The core and shell are what my body temperature is. I described that earlier when we talked about IV saline. And really what I have in my body is my total body heat. Temperature is a metric that represents how much heat is in my body, how many joules of energy is in my body. And it's really the temperature times the mass or the thermal mass of each of those compartments. And what determines my temperature, or my heat content, is how much energy I'm producing, just like that toy model, and how much heat I'm radiating. What's my heat flux? Those two things have to balance. If they don't balance, then I'll generate heat and I'll catch on fire. And if they are in negative, then my body temperature will drop. So, the same thing is true in the animals. When animals, like that bear hibernating, goes into hibernation, they lower their metabolic rate. He curls up, lies down, his metabolic rate goes down. See, in January, metabolic rate, the VO2 on that bear is lower. But the temperature of that bear is not really reaching its minimum until later. First, the metabolic rate goes down, and then the temperature goes down. So it's not wrong that lowering the temperature lowers metabolic rate. That does happen, but it's not the trigger. When people enter or animals enter hibernation, first they lower their metabolic rate, and as a consequence, the temperature goes down because your heat flux is still going on. And we were actually set up to measure that in the laboratory. So I had put thermometers on people's skin, and I had thought, ultimately we'll have to monitor, is the person cold or not? Maybe I can do some kind of math with the skin temperature. And, if I put a blanket over the skin, it would warm up, and I took the blanket away, it would go down. It was very chaotic. The data from skin temperature was not very easy to interpret. But the devices I was putting on people actually let me measure heat flux. So like those cooling pads, they put water against the skin, and then the water comes back. The water changes temperature as it touches the body. And I can read that out of the machine, do a calculation, and tell how many watts of energy is coming off of that person. And I can also measure the calorimeter and say how many watts of energy is that person making. And when the person is cooling down, the machine is pulling more watts than their body is making. People at rest make about 80 watts of energy. And the Arctic sun will pull 150 watts off of the back. So if I leave that running for a couple of hours, the body temperature creeps down. If I shiver, then my 80 watts of energy production goes up to 150, and my body temperature doesn't change. So again, think about that when you're doing it in the ICU. We got better heat flux measures. When we understood that, we threw away the skin temperature probes, and we bought skin heat flux sensors, which engineers have to measure all sorts of things, and just put those in different compartments. And now I understand that your head is a radiator, and it puts out about 80 watts per square meter of heat. Your abdomen is a little bit behind it. Your arms and legs generally don't radiate nearly as much heat. And if I want to figure out the total heat flux in a person, I just need to take the body surface area of each of those things and what the heat flux is of each of those compartments. And if I add them up, it actually makes sense. If the person's temperature is constant, then all those things add up to 80 watts, and their metabolic chart says they're making 80 watts of energy. If the person's cooling off, then they are making less energy than the radiation. It was kind of a cool thing. I realized that measuring skin temperature is not the thing. I want to measure skin heat flux. The bears taught us, and the data was there for us to see that that was going to be the case. First, the rate decreases, and then the temperature decreases. You also get up and move around a few times in the den, just like what we're planning for the astronauts. They don't sleep completely motionless for 6 months. They also keep their body temperature above 30 degrees. This is another important safety tip. Bad things happen to your heart under 30 degrees. Bears' hearts are similar in size to our hearts. It's a whole nother digression about ventricular fibrillation from hypothermia, but you see it in the operating room when you do open chest and you lower the body temperature, the heart will fibrillate, and then it won't really get back until you're warm again. There are electrical changes that happen in that temperature range. And if you get under 30 degrees, you can get prolongation of the action potential, changes in conduction velocity, and these things can be pro-dysrhythmic. If you stay above 30 degrees for a large heart, an animal with a large heart like us, you're probably okay. It's not as likely to happen above 30 degrees. So when bears hibernate, they stay above 30 degrees. Squirrels, small animals, they hibernate down to like 5 degrees or even freezing. This is okay because, interesting basic science fact, ventricular fibrillation is not lethal in little animals. The hearts will fibrillate and then they'll spontaneously defibrillate. It's only when the heart is bigger than about the heart of a rabbit or a small dog that ventricular fibrillation is fatal. So that's a thing that is a problem for us because of our size. If we were the size of a squirrel, then ventricular fibrillation would just be, a dysrhythmia, and it would be transient and it would spontaneously defibrillate. So it's a geometrical feature of hearts. So that's why bears hibernate at 30 degrees, not 5 degrees. And that's why we should aim for that as at least our first pass for astronauts. Okay, data. What drug am I going to use? Dexmedetomidine was my favorite. I gave the same dose sublingual. I showed you those data. Those are the individual people. Metabolism drops, last about 2 hours. Blood pressure okay, heart rate okay, get that bradycardia down to the 40s. Breathing unchanged. 4 micrograms dexmedetomidine swallowed. So we didn't put it under the tongue, but we had people swallow it. And it was more reliable, lasted longer, but didn't drop the temperature quite as much. But, at least proof in principle that we can use this non-intravenous dexmedetomidine. We tried tizanidine, and it worked in 90 to 120 minutes, lasted about 4 hours. It was a little bit harder to dose. The higher dose worked better, lasted about 5 hours, and people were very orthostatic and had a lot of symptoms at the end of the day from the tizanidine. We drew drug levels, and we got a feeling for where we were in the range. You can see for the dexmedetomidine, it was, again, in the 0.2 to 0.5 range was where below 0.2 was probably not adequate for suppressing shivering. But once we get up in the 0.5 range, we were having reliable effects. It also showed me with the oral dex, some people just didn't seem to absorb it. I don't know if it bound to food, but that's what's reported with swallowing dexmedetomidine is sometimes it works great, sometimes it seems to be lost in the first pass. So you're not quite sure what's going to happen with the person you give it to. And remember this model? What I wanted to do was to see if instead, as the person cooled, did their metabolism go up or did it go down like the hibernator? So these are the graphs from our volunteers. And with sublingual dex and the low dose of tizanidine, as their body temperature dropped, the metabolism went up. It's no good. But with the higher doses of each, it was flat. So at least in those high doses, we were getting the effect that made people look like hibernators. What I really was hoping for is it would be going down. One mic per kilo is probably not enough. So what I really wanted was more dex. And the best thing would be if I could make a patch, something that was reliably absorbed or a depot. It doesn't exist. I discovered there's a lot of laws. You can't just make up a drug in your basement and then give it to a lot of people. But we're working with the pharmacists who know how to do that. And maybe a year from now, maybe we'll have a patch or a topical form of that drug. In the interim, to imitate that, I got the subcutaneous needles that you use for an insulin pump. So people with diabetes use this all the time, every day for long periods of time. You can put it in usually for 2 or 3 days and then rotate where you put it. So it's minimally invasive. It kind of violated one of my rules of no catheters, but it's imitating a patch. And just ran an infusion pump. And we got cooling that looked like this, 1 mic per kilo per hour. The temperature goes down 2 degrees. Doing it for 6 hours. There's a big drop in metabolic rate, it's kind of in kilocalories, energy expenditure. And then you can see that top one, it looks like the temperature is going down and the metabolic rate's going down even further. Averages over groups are the same kind of pattern. And I'm going to flip the axis so I have temperature on the bottom and metabolic rate on the y-axis. And you can see that now that curve is going down. So in the first experiments, I got it flat with a high dose dex. Now with this really high dose, I'm actually getting curves that look like hibernators. Metabolic rate's going down with temperature. There's a drug-induced decrease and then a temperature-induced increase on top. If I plot it, I get about 75 kilocalories just from getting the drug, and then 100 calories for each degree that my body temperature falls. And by lowering the body temperature from 37 degrees to 35 degrees, I get a total of about 25% reduction in basal metabolic rate. That was my goal. Drug levels, more reliable. Discovered that those needles, sometimes you can get an intradermal injection. It's not good. Leaves a big blanched spot, which made me very nervous for a day. So I watched that closely. It also didn't work. That person did not get sedated. Solution was, if there's a little bit of adipose there, I just got longer needles. So, if you get a longer sub-Q needle, it's eliminated the problem. But you can see those people didn't really get their dose there. And you can see the happy range, the plasma levels that we're after are 0.5 to 1. Those are the DEX. People have sedation. If we look at their reaction time, definitely goes up after the dexmedetomidine and doesn't recover quickly. So people have a carryover for a number of hours. And it looks like the bear. So I'm really happy because here for 6 hours in this setting, we have a person whose temperature is 35 degrees, their heart rate's in the 30s, their metabolic rate is 25% lower than their basal metabolic rate on a normal day. They're hibernating. That's kind of cool. So that's kind of phase 1. We can suppress metabolic rate. We can suppress cold-induced thermogenesis. What we need to do is to see, can we do it for days and weeks? Because that's the astronaut challenge. So everything I'm going to show you here is what we're about to do kind of when I get back from this trip. We're going to try it for 1 day, not just 6 hours, but the full 20 hours. And then we're going to try it for 5 days. And that's what we're funded to demonstrate. For 1 day, it's going to be a similar study, but instead of those 6-hour experiments, we're just going to do it for 20 hours, and then we're going to have the person recover and do all sorts of testing before and after to see that nothing bad has happened. I think the dose will be, well, our doses we're proposing is 0.75 and 1 mic per kilo per hour of DEX. If 1 day works with those doses, we're going to take the most tolerable dose forward and do it for 5 days. We'll have them sleep for 20 hours, get up, exercise, eat some stuff, and turn the drug back on and have them sleep another 20 hours. Have them get up and just repeat 5 times. And that'll be our demonstration of cold sleep for long duration. One thing about this is we can't use the metabolic cart. I can't have them really under a bubble for a week. I could, but it's very inconvenient. People can't turn over, they can't go on their sides. So we're trying to get less invasive monitors. We're going to use doubly labeled water as a technique for measuring metabolic rate over 5 days. And while I'm here, our laboratory is doing a control experiment where they're having ambulatory people use this technique to measure metabolic rate over 1 week. It's a slick technique where if you drink heavy water with oxygen and hydrogen isotopes that you can measure with mass spec, when you pass urine or sweat, you excrete the hydrogen and oxygen. but you also exhale oxygen, but no hydrogen in your breath from oxygen that got into the Krebs cycle. So the difference in disappearance of oxygen and hydrogen tells you how much metabolic rate you had averaged over time. It's really slick. It's non-radioactive. It's very reliable. It's really expensive. So, you get the heavy water like from the, Nuclear Regulatory Commission, and they send it in a thing, and, it's, we called it space water. So, you have to drink the space water. And I told the people in the laboratory that if we spill it, we're going to lick it up off the floor because it's really expensive. But a really good technique if you want to study metabolic rate, say in a hospitalized patient over a week. Can't really put the metabolic cart on them for a week, but you could do this over a week. 5 days will look very similar, and we'll see how the people tolerate it. And we're ready to do it. So, some where we are. You can get DEX, minimally invasive techniques. If I can get plasma levels in that range, I suppress shivering, cold-induced thermogenesis, let the core temperature fall safely 2 or 3 degrees, and I lower my metabolic rate by 25%. Safety is okay. There's some hangover, and I've mimicked many desirable features of animal hibernation. If we do this, things we don't know, and every researcher thinks, well, like, what are we going to study next if we can pull this off? What kind of exercise do you do? Do I get on the treadmill, or do I do, resistance exercises, or what's the best thing to keep my muscle health? If I'm hibernating, do I have as much muscle and bone loss as if I'm just at bed rest? Does this actually protect me like the bear? What do I eat? Hibernating animals are pretty much burning fat. So if I get you up, are you going to want, pasta or oil? I mean, it's going to be, what is the diet that is optimum for this? And how long can we do this? If I do this for 4 days, does everyone say, no, I'm not doing it, I quit, I'm out of the experiment, I'm not going to do this even one more day? Or is it, something where it's fine and you can tolerate it? What are the psychological effects of sleeping your life away for days at a time? And then, why bother? Whenever we do NASA work or space work, the agency is very good and careful to remind people that it's fun and cool. And, talking about like going on long missions is attractive, but you need to do things that are going to benefit everybody. The analogy, I always make is 12 people went to the moon, but 1 billion people get cell phones. It's the same technological effort to do the first has resulted directly or indirectly in the second, and many other things that are spin-offs. So what are the spin-offs? Well, surviving in a spaceship is not different than if your submarine sank and you have 5 days of oxygen, but the rescue is taking 7. Doesn't matter if the rescue takes 6. You only had 5 days of oxygen, plus you hibernate, then maybe you had 8 days of oxygen. Radiation protection, didn't even think of that when I began. But if I'm going to irradiate your tumor, maybe it would be good if the rest of your body was a few degrees cooler, so you have less burns and less collateral damage when I irradiate that tumor. We talked about ischemia and trauma, and then what if I'm having my multiple sclerosis exacerbation? Remember how temperature makes it terrible? What if I could hibernate the next 48 hours and have a lower temperature for the next 48 hours? Would my MS flare go down, or some other inflammatory condition? Don't know. Areas to research, things to consider why this exotic thing of sending people to Mars may benefit some people on Earth. I covered a lot of things and made you think about physiology. You hope you had forgotten. You saw math. I'm having fun with this. I learned a lot. And we think the project has got applications outside of just going to Mars. So I wonder if there are questions about it or other things, or if you think we should close it up and go back to cardiac arrest research. So thank you guys for being here.